So I am Nick Cohen. I'm a PGY3 resident in family medicine. It is great to see such a good turnout. We specifically invited the whole department because as we're learning to work as teams, every member of the team is essential. And so getting your input as we design ways of improving the quality of care we give it's great to have a whole spectrum of people. It's also good to have medical students here because I think this is a model for practicing family medicine going forward, so you can get a good idea of how cool it is to be a family doctor. So I have probably 3 minutes left, and I'm going to keep on schedule. Our objectives today are to become familiar with NCQA, which is the National Committee for Quality Assurance. They have a patient medical center home standards they published in 2011. They basically tell practices you are not a patient-centered medical home. Today we're specifically focusing on managing populations, which is a huge component of what is considered a patient-centered medical home. We have baseline data on each of the teams, and more data is forthcoming from EMR support in the next 3 weeks. The idea today is for you actually to plan a quality improvement project based on the data that your team's going to have. So I see Sonia in the audience. I don't think you're on a team. You are on a team. Okay, perfect. I didn't think you were. I just want to make sure everybody's on a team. So we talked about the NCQA. There's the organization's CMS, Center for Medicaid Medicare Services, has reimbursement that they base on specific quality measures. Meaningful use is one category, PQRS reporting, which we do when we check off that we're doing tobacco counseling, for example, or that an A1C has been done in the last 90 days. Is a way of incentivizing primary care practices. And a lot of the goals of CMS and NCQA are becoming concordant as we go forward. We have a survey tool. The NCQA makes it very easy to know where you stand as a PCMH with an online survey tool. NCQA level 1 is a score of 35. I assessed ourselves a couple days ago. We're at about an 8 right now, and a huge part of that is not having an electronic medical record. Population management, though, even without an electronic medical record, is such an important component of patient-centered medical home that we could achieve a 28-point increase in our current score. We could have enough points to become a level 1 PCMH just by meeting the criteria that NCQA holds practices to specifically for population management. So in their criteria, they ask for practices to collect data and demonstrate improvement on 3 preventive care services, 3 acute or chronic conditions, and one of those conditions being related to unhealthy behaviors, mental health, or substance abuse. To implement evidence-based point-of-care reminders for each of these, to measure their performance, set goals, and act to improve performance, and demonstrate improved performance. That's what we're hoping to start today. So we're hoping, with the data that you get, to come up with ideas to improve your baseline data and to remeasure your data in 2 months. Share lessons learned with the practice, and then consider as a practice what worked and what we might want to implement practice-wide. So with the help of IDX and now with EMR support, we assigned a chronic or preventive care service to each of the teams to look at, to pilot an intervention to improve their own team's data, and then to share with the practice what worked. You can see them here. Diabetes for purple team, tobacco use for green, depression for orange team, cervical cancer screening for blue, breast cancer screening for pink, and colorectal cancer screening for yellow. So a note on the data, your continuity list all exists on the S drive, family medicine, PCMH, green team, blue team. The data for that's not specific to lab results, like all women age 50 or over, is already there. The data that involves actual values like hemoglobin A1Cs, I just did a sample size of 50 to 100 to look at it. I didn't have the ability to do a broader search. EMR has a report, and they're doing that in the next 2 weeks. They'll have it done by October 1st to give you your A1Cs for all your diabetics. I just have a sample now. So I'm going to hand the podium over to Dr. Gullett. Dr. Gullett's talking to us about population management as it pertains to diabetes. Then she's going to discuss cancer screening as it pertains to, or population management as it pertains to cancer screening.
Here's some more handouts for folks who are coming in. So it's a great problem to not have enough room. This is very exciting. We really are excited about the information that we have to share today. And this is just the beginning. We're hoping that we'll be able to drill down a little bit more over the next couple months with the data that Nick has come up with using our current hospital EMR system, which isn't even fully realized yet. So this is pretty exciting. One of the things that I will keep reminding everybody is the levels of prevention. And the reason that this is important is that I want everyone on every team to understand these levels, because sometimes it's unclear why we're doing cancer screening. And so you need to understand, where are we aiming at, right? So when we do primary prevention, we're aiming at preventing a disease before it happens. We do this by vaccinating most often here in the office. Secondary is what we do when we do Pap tests, mammograms, colon cancer screening. This is detecting a disease before it's clinically apparent. It's there, but it's not apparent yet. Therefore, we can actually try to treat the disease at an earlier stage. So we're doing both of these. In tertiary, we're getting at things like diabetes. We're trying to prevent the complications and mortality associated with a chronic disease. So each one of our teams, and everybody on those teams, is really important at getting at each of these three things. We're delivering prevention at a number of levels. And so I sort of want, that's the big picture, and I sort of want everybody to see that. So what has happened is Nick has been working with our IT colleagues, who you'll remember came to a couple grand rounds ago, and they've been working tirelessly at trying to pull data for us. We can't use the notion of not having a formal EMR as a crutch for not actually going forward with patient-centered care. There's always going to be another step we could go to. So what we've done, and what Nick has really worked hard at, is pooling data for you to use in your small groups. So this is a brief overview, and most of the time today is going to be spent in your small groups. Each team has been assigned one of the chronic disease population management topics, and each of you have some wonderful data to start with. So the purple team has 103 diabetics that have been pooled from this EMR work that Nick's been doing. 13% of the patients on this panel have diabetes, and he's included some of the statistics from the United States just for comparison. Their average A1C is actually not so bad for these patients. So basically, we've pooled the lab data with the panel of patients, cross-referenced them, and then come up with an average A1C of 7.4. But you'll see you have a number of folks with very poor control. And then you'll have a number of folks who also haven't actually had it checked in 90 days. And when you do chronic disease management for diabetes, one of the important process measures, which we'll go over in a minute, is actually checking a regular A1C, so every 90 to 120 days, so that you have accurate information to work with. So what's optimal? Well, after this grand rounds, I'm going to send around a document that's published annually every January by the ADA. For the purposes of our program work here, for cancer screening prevention, we are using the recommendations provided by the U.S. Preventive Service Task Force, or the USPSTF. For diabetes management, we're using the recommendations of the ADA. Those are the groups we're going with. There are a lot of recommendations out there, and it's really out of the scope of this program here for us to debate which ones we should be using. These are the ones we've decided to use, and we can talk about that more later if you're concerned. But the ADA is giving us what we need to do for diabetes management. And it's a very nice 7-page executive summary is what I'll send to you. But they tell us what are the process measures we should be using. And each of you has these in your slides, so you can refer back to them as you start to brainstorm, the purple team starts to think about what they can do for diabetes. You'll notice that the process measures are things like actually getting the testing done, right? We can't really partner with a patient if we don't have any clue what their control really is. So a process measure is an interval step to improving outcomes. It's actually getting the test done and then talking about what those results are. So those include things like A1Cs, lipid panels, testing for nephropathy with a spat urine, blood pressure testing. You'll look down here, there's self-management. We talk a lot about self-management, but we don't really talk about how to make that happen. Medical nutrition therapy, physical activity guidelines, the use of aspirin, and then vaccinations. As you all know, vaccinations are near and dear to my heart, and I'm always harping away at, did they have their pneumovax? Did they have their flu? Well, in diabetes, this is super important. And you'll notice there's a new recommendation for hepatitis B to be given to your adult diabetics as well. And then down here, smoking cessation, which Dr. Stange is going to talk about briefly. Outcome measures are things that we want to actually improve. Sometimes those outcome measures aren't things that we're going to measure for a number of years. So, of course, we'd love to follow our cohort of diabetics and say we reduced the number of myocardial infarctions, but that's not something we're going to measure in the next 6 to 12 months. So we need to do other outcome measures, which are interval improvements in hemoglobin A1C, improvements in the degree of proteinuria, things like that. So we're going to work with you in your small groups to sort of identify what these things really are. Okay, so I was just sort of mentioning these a little bit. In the intermediate and long-term outcome measures, these are just some that the ADA purports. I want you guys to come up with ones you really care about. What's feasible? What can we really measure? And so these are just to give you some information as you're breaking into your small groups. We're going to float around and give you some guidance. This is more of a working slide for you to go back to and say, what exactly does that mean? What can we really do here? What can we think about? All right, so several other groups have been given cancer screening recommendations to use to implement in our practice. This is one that tends to be really confusing for a lot of people. I know we've had a flurry of emails recently about, do we order HPV? Do we not order HPV? What age do we order it? Only some providers like HPV. So basically, the USPSTF changed the recommendations in 2012 for cancer screening guidelines. You'll remember, cancer screening via a pap test is secondary prevention, right? We are looking for subclinical disease. It's there, but not clinically apparent yet. So that's what we're trying to get at here. This is not a patient who's had an abnormal colposcopy and is coming back in for pap follow-up. That is a different situation. This is all comers with no disease, no history, routine screening. Okay, that's what we're getting at here. So the USPSTF has said, under 21, no screening for the average population. There are rare exceptions to that. We don't typically see those patients. Those are people with chemotherapy, backgrounds, history of HIV/AIDS. Those aren't people we normally manage here. You can look at the exceptions on the website if you're interested. Most of the people we manage are the average population, 21 to 29. Reflex HPV on your pap, and then you can go to every 3 years if normal. So when you're coming up with what you think we should do as a practice for this particular screening guideline, think about that. It's not an annual pap anymore, and that's sort of a hard thing to re-socialize patients for. Sometimes I have a hard time convincing people they don't need a pap every single year, particularly those people who are over 65 and have been getting them every single year for the last 30 years. The next group is those 30 and older. We do a mandatory HPV on those folks. They can actually go to every 5 years. If we don't, they can stick at the every 3. But actually, it's kind of a good idea to do the negative HPV, check for negative HPV so they can space to 5 years. So just think about these guidelines when you're thinking about how should we implement this. And then over 65, if they have had normal screening and they're basically a normal average patient, no more PAPs. I can't even convince my own mother that this is an important intervention to stop having. So it's going to be hard to convince your patients, but this is what the evidence is guiding us. And then women without cervix. I see lots of women come in who either don't know if they have a cervix. I had a hysterectomy. I don't know if they left my cervix or not. Go look for it. If it's there, do your PAP and manage them accordingly to their age. If there's no cervix there and they did not have cervical cancer or high-grade dysplasia, meaning CIN1 or 2 or 3, not CIN1, but 2 or 3, stop doing PAPs on them. So we wanted you to just have an exposure to what these guidelines say. You don't have to commit them to memory today. They're easily looked up. So the blue team, this is your charge, okay? We have information on PAP screening between the ages of 21 and 65 in your panel. And we want you to think about how are we going to do this as a practice. Your panel is going to be the first sort of pilot for cervical cancer screening. These are the data you have to start with. Where are we going to go from here? Yeah.
I'm commonly finding women 18 to 26 do not have HPV vaccine, and I wonder, again, it's a little complicated. It's a separate kind of issue, but those young adults that may or may not have this disease, I think it's worth kind of considering.
So that's a great primary prevention piece here. And we can definitely work with the Blue team to integrate that into a protocol. Dr. Rose has spent a considerable amount of time implementing a protocol at the health department for those who don't have coverage for HPV vaccination. And I'll remind you that VFC covers up until the age of 19. So please vaccinate anybody, even if they're here for a cold. Offer it to them. We can really get, if they're Medicaid patients on VFC, we can definitely get them vaccinated. Okay, next screening is colorectal cancer screening guidelines. USPSTF, age 50 to 75. You do not have to have a colonoscopy, okay? FOBT counts, colonoscopy counts, FlexSig counts. Beyond the scope of this discussion here to debate whether we want to recommend one or more, one of those over another, but the USPSTF has done exhaustive research on the evidence behind these, and they say that it's appropriate to do one of those three things. Again, this is not a patient with symptoms. That is not secondary prevention. That is not screening. If they have symptoms, that's diagnostic category, and not what we're dealing with here. 76
Let me just say, screening with FOBT is not a rectal exam by itself.
Right, that's testing for blood. And each of these guidelines has specific evidence which the teams can go to themselves. This is a very brief overview so that we can get you into your teams, and we'll be available to talk with you. Over 85, no screening. In between 76 and 85, recommend against routine screening, but you'll still have people who really feel like they need to have it done. If they've had a prior history of colon cancer in that age group, that's not screening, okay? They're in a different category. It may be called screening, follow-up, post-colectomy or something like that, but it's not really screening in this sense. Okay, yellow team. Right, right. And so that's not all comers. These are all comers, average population, no reason to have an earlier screen, and no symptoms, okay? Yellow team, this is your charge. So 406 patients on your panel, 50 or older. We don't have a high-end cutoff here, but we're just assuming that that is the group that needs to be screened. 38% have received a colonoscopy. Now, you can say, okay, maybe they went to another health system and got their colonoscopy. There are a lot of exceptions, but basically we're starting with the data we have and moving from there. Clearly, there are patients who could be screened who haven't been. And this is just an Ohio statistic for comparison. All right, this one is controversial. We're not going to debate whether the USPSTF guideline is what you want to go by or not. What we're just going by is what their recommendations are for women 50 and older, all comers without symptoms and without a family history. Same is true for the family history piece here. So they're recommending biennial screening mammography. This is the standard by which we are going to encourage you to come up with some practice recommendations. Yes, there are groups who want to be screened younger. Yes, the American Cancer Society says something different. We're simply going to use this for the purposes of being consistent. The evidence actually has been vetted pretty significantly through the USPSTF. So pink team, this is your charge. The cohort that has been evaluated for your patients, 16% of them are 50 to 74. 50% of them did not have a mammogram in the past 2 years. So again, we're using the biennial piece here. And this is within our health system. So yes, they could go somewhere else. They might have an OBGYN. They see who orders it for them in another health system. All right, so we'll figure out a way to track those people. But the bottom line is we're still missing people in our own health system. All right, so I finished 1 minute over. I'm going to turn over back to Dave. Oh, I have one more thing to say. Thank you all for the great huddling that's been going on. I'm super excited. But I want everybody to know that today's team meeting is a huddle. So every single team needs to send me at least huddle number, one huddle for the week. Nobody gets a free ride this week, all right? Because there are some teams that can still improve the huddling, but several teams have been doing great. But this one counts. It doesn't have to be just a clinic session.
So I'm impressed at what a fast and furious mind dump we're doing on you today. And so don't be too worried about that, because we're going to have multiple chances to get back at this. The big idea here is that mostly what we do now is we see patients as they come through the door. We see them one at a time. We think we're doing God's work because we helped a few people. Hopefully, we listen to some other people, and we go home exhausted at the end of the day. This is a pretty big switch. We're asking us to think about our patients as a group, and how are we going to look at where we have evidence that doing certain things to people as a group, individually, but looking at them as a group can make a difference. And that's a big change. But it's how we're going to actually make sure that we actually maximize the impact that we have on people's lives. Because just reacting to what people come in, we don't always focus our energy on what the most important thing is. And to do this, we really have to have everybody in the practice involved. This isn't just about getting people in the doctor and the patient work together. It's about getting everybody involved, figuring who's the population of interest, who has a chance to touch that patient, what do we do when. And the way we're doing this, I just kind of realized that's one of the brilliance of this approach. So having the different teams choose something different to work on, we're going to have chances to come back at this because the teams are going to do one little thing. They're going to do something to get started and learn from that. And then we're going to share. And the teams are doing such different things. What one team is doing for one thing, there'll be a good idea for what another team is doing for another. So I think there's a lot of material here, but I think we'll have multiple chances to come back at this as we're doing this. Each team is doing stuff, learning from it, sharing with the other team, going back and learning and doing more. So I think it's actually a pretty cool approach. So this is a start of something that's going to be a lot of work. So who's on the orange team? Okay, no, that's good. I see. So you have a really cool but hard but potentially really transformative thing working on depression. Because there's a lot of new resources that are potentially coming to play here that we haven't had before. So just from the data Nick got, 70 patients identified with already having a diagnosis of depression. That's a little bit less than the Ohio average was 6%. And so it probably means that we have people that are depressed that we don't have recorded yet. So there's two ways to really think about approaching this. One is you can think about what are you going to do with the people you already know are depressed. And that's pretty important. The other is how are you going to identify the people that are depressed that we just really don't know about. And you know, some of those patients, we know about it, but in different ways. They're the ones that are calling all the time, or they're calling after hours, or they're just coming in for multiple chronic complaints that you don't seem to be able to do anything about. And so those are two different things that the Orange Team could do. The U.S. Preventive Services Task Force does recommend screening for depression, but only if you have something you can do about it. So you could either look at screening, but think about what you're going to do about it makes sense. One of the things that's really being used at a lot of places around the country is the PHQ-9. Raise your hand if you've heard of this or seen this PHQ-9. Are we using it all here? Some people are using it. So that's a tool you can use. There's a 2-version item that you can use just as an initial screen. Some practices, like the practice I practice in, we do the medical assistants when they put the patients in the room do the 2-question screen. If that's positive, go ahead and do the full 9. That's one way to do it. And then the question is, what do you do with a positive screen, or what do you do with the patients that already are diagnosed with depression? And certainly you've got the connections here, which we didn't have when I was here before. Nick made the suggestion here, which I think is a good one, to think about getting a brochure of the community mental health resources that are available beyond connection. So we have community mental health centers. We used to have that here when I practiced here. Actually, I don't know that we used it widely, but I think I got it from Joyce. Actually, I think someone gave me a list of this, and so it was nice for people that didn't have other options. And of course, you can refer people to the friendly toll-free number in the back of their insurance card. But this is where something cool is happening. So the Orange Team, you might decide to do something quick and dirty that you can do now. But we've got new resources coming in here. Social work being hired. The opportunity to talk to that social worker about what is her role, what does she want to do, what is she able to do to potentially have some resources right in the practice for mental health things, for getting some help with the patient right that day. So there's some fun things to talk about there that you won't be able to act on right now, but there's some things you can do with this going forward. Tobacco use, 33% of the Green Team members smoke, which is higher than the Ohio average, which is already higher than the national average. So this is something that it's easier to do something right now. I think one of the key things is to think about who does what on this. And one way of thinking about this is the 5 A's. So ask is just asking the patient, do you or anybody in your family use tobacco? And if the answer is no, great, you can move on. If the answer is yes, assess means assess their readiness to change. Are you interested in quitting now? If the answer is no, you can stop there too. But first you say, I'd like you to think about quitting. It's probably the most important thing you can do for your health. So this is actually a time-saving way. You don't want to hammer on people who don't want to talk about it that day, but you want to use your chance to give a message. Just asking and assessing takes really 15, 20 seconds tops. And it's a way of screening people. Now if they say, well, yeah, I've actually been thinking about quitting. Okay, then you're advising. You maybe ask, have you quit before? The answer in everybody is yes. Maybe it's for one day. What did you do before? What worked? I'm shocked at them. People say, yeah, I quit for 2-3 months. Well, that's something to build on. Build on the strengths. What do they do then? So you can do that. You can think about who does all of these. One of the medical assistants I used to work with here had recently quit smoking, and she apologized to me once for being a little bit late getting out of the room because she had just counseled a patient about smoking. She said, that's great, because I'm sure you connected with her as a recent former smoker in a way that I, as a white male in a tie that's not even didn't inhale, I've never even lit one up. So that's great. So you might decide that the nurses on your team are going to actually do some of the advising and assisting, or you might decide they're going to do a screen and then hand off to you. But thinking about who does what, and assisting, and then is getting some help, and then arranging follow-up. So you all know about the quit line, I think. I'd recommend go to the website if you haven't been there, and just look to see what the options are, because you can do a better referral to the patient if you know what's there, and you can tell patients what to expect there. And then thinking about learning how to do brief counseling, 4 minutes or less, which is one of the standards that's used, because actually 3 or 4 minutes of counseling has been shown to be more effective than brief counseling. But frankly, just doing brief counseling in this kind of screening kind of way, that's good too. So and there's lots of things you can choose to do there. Oops, I already started it. Oh no. Okay.
All right. So in the next 15 minutes, we're gonna relocate some groups so you'll have a little more space, and we'll come and get you in 15 minutes. The goal is to, for your project, just set an aim, and maybe try to make it specific. Like, what's your percentage of women who haven't had a mammogram who are age 50 or older, and then think about a 2-month time frame for achieving whatever specific goal that you set up. And then I would suggest, it's very hard to get to details at this moment, but maybe set up how you're going to meet, maybe divide responsibilities in very broad ways across the team. Do what you can in the next 15 minutes as a team, and then at 15 minutes later, we'll go around the room and present your general thoughts about your quality improvement project.
Okay, guys, so not everybody's back, but we're going to go ahead and get started because we need to be done promptly at 9. So I just want to make a big picture comment, sort of 30,000-foot view, is that all of this is small interval change to a bigger picture, and we want you ultimately to develop some systems, interventions, and the practice that can be shared with other groups, so we're not all having to reinvent the wheel. We're doing a little bit and then sharing it, what works with everybody else. So that's the big picture down the line. What we need you to do right now is articulate an aim to us on your assigned population management topic. So just articulate that aim. It can be as brief or as wide as you want it to be. But over the course of the next 8 weeks or 2 months, we want you to continually do these PDSA cycles that we talked about a few groups ago, to reach that aim. And those things can be continually redefined. This isn't rocket science. So please come to us with questions. How does this work? What do we need to do? And these can be as small as need be to make some change. We want you to get some small wins early. Early small wins sustain this sort of a process and make you actually excited about your job. So Dr. Cohen's going to go through each group. Just give us your aim. And if you have a first PDSA cycle, go ahead and give us that too.